All right, good morning. Thank you so much for this honor and the opportunity to share our work with you. We want to thank the Department of Surgery for a seed grant that helped fund the initial efforts of this project that we're able to share with you today. And we have no other relevant disclosures. As many of you know, viral hepatitis is the most common indication for liver transplantation worldwide. In the United States, non-alcoholic fatty liver disease is the second most common indication for transplantation. And with the rising obesity epidemic, this is projected to be the most common indication for liver transplantation in the United States in the next 10 years, making this and hepatic steatosis also an important characteristic to identify on potential donor liver grafts. The process of proceeding for liver transplantation is threefold. First, assessing the compatibility between the donor and the recipient, the quality appraisal process of the donor liver on biopsy, and lastly, the technical process of proceeding with transplantation as well. Our team felt that the quality appraisal process is the rate limiting step, and this is where we sought to make improvements. So steatosis is an important characteristic to identify on donor livers because this has been associated with a greater risk for early allograft dysfunction when present. And in fact, some donor livers with isolated steatosis greater than 60% that are otherwise viable could be discarded and not used altogether. Recent literature, however, has shown that increasingly steatotic livers can be transplanted safely without the same associated risk for early allograft dysfunction, or EAD. And a report from the pathology literature last year may be able to explain why, showing significant inter-observer variability when two different pathologists scored steatosis on the same slide. So, with many livers being discarded because of high degrees of steatosis and disagreement between multiple pathologists when reviewing the same slide, we thought that a more objective process is needed to determine the degree of steatosis involved on a viable, otherwise donor liver. And we thought that artificial intelligence was a well-suited platform to address this problem. For all the buzz that AI or machine learning gets, there are essentially higher level versions of statistical programming with many different options. One option that I've shown here, known as artificial neural networks, functions similarly to a statistical test where you have a pre-specified input that then has this processing algorithm here and a desired output. And the processing can vary. In this case, with neural networks that are modeled very similarly to neurons within the brain, you have multiple layers, or what are called depths of processing, that take certain features of an input and identify their correlation with an output of interest. This can also be done with words out of the electronic medical record, or you can also use images from laparoscopy or even donor liver slides. And when images are used, this type of machine learning is known as computer vision, where certain texture features of an image are identified and sought for correlation with an outcome of interest. So for our study, we identified all donor liver biopsies done at our institution between January of 2014 to November of 2019. We digitized these slides and they were reviewed and annotated by two independent pathologists to consensus, as shown here. This slide was then marked up in blue with spots that were associated with steatosis per the pathologist. And then from these images, distinct tiles were generated to help train several computer vision platforms that incorporated fully convolutional networks, which are a form of the neural networks I showed you earlier. 4 different models of increasing complexity were made, and there was a different training set as well as a prediction set that was able to test for the accuracy of each of these models using a metric from the artificial intelligence literature known as the mean intersection over union, where a higher number indicates better accuracy. Early allograft dysfunction was defined as the detection of total bilirubin greater than or equal to 10, or INR greater than or equal to 1.6 on the 7th day after transplantation, or AST/ALT greater than 2,000 within the first 7 days of transplantation. So during the study period, 91 slides were identified, of which 42 went on to transplantation. Of these slides, over 25,000 images were generated, of which 255 were used for training, and the remainder were used as part of the prediction set. So I'm showing here the original image and an example of the pathologist labeling on the right. The first model, known as the fully convolutional network with a depth of 5 and a resolution of 256, as you can see, seemed to overcall some areas of artifact on the image relative to what the pathologist had labeled. A more complex version of this, with a depth of 10, seemed to overcall less than its predecessor. A more complex version than that, also a fully convolutional network, but with the name shallow UNet, seemed to overcall less than their predecessors, but still more than the pathologist labeling. And lastly, a more complex version of the shallow UNet, a deeper version, simply known as UNet, seemed to overcall the least, and at least visually seemed to represent what the pathologist had labeled the most of the examples I've shown here. We then took the models and then arranged them by increasing complexity here on the x-axis from left to right, as well as the increasing number of images used to train the models here going upward. And as you can see, the shallow UNet and the UNet platform seem to achieve the peak mean intersection over union of 0.80, not just with the maximum number of slides used for training, but also with half the number at 90 as well. We then took the UNet platform steatosis scores and compared them to the steatosis scores from the pathologist, and found that the median steatosis scores by the UNet platform were significantly lower than that of the pathologist. When looking at only those scores by the slides that were transplanted, there was no significant difference here. When looking at those that were transplanted and developed early allograft dysfunction, again, the UNet platform scores were significantly lower, and there was no difference between the transplanted slides that did not develop EAD. We then compared the steatosis scores from the pathologist between those that did develop EAD versus those that did not, and there was no statistically significant difference here. However, when we compared the steatosis scores by the UNet platform for those that did and did not develop EAD, there was a statistically significant difference, but as you can see, not a clinically significant difference. We then plotted the slides here on the x-axis by increasing UNet steatosis score going from left to right, and also charted here in blue. And we also scored the steatosis here on the y-axis going bottom to top, and we also compared this to the pathologist steatosis scores here in orange. And as you can see, after the steatosis score was assigned greater than 20%, there could be as much as a 4-fold difference between the UNet steatosis score and the pathologist steatosis score. We then performed a Cox regression analysis looking for variables associated with the outcome of early allograft dysfunction. And on univariate analysis, recipient MELD and AI steatosis score, but not pathology steatosis scores, were candidates for inclusion in the multivariate model, which found recipient MELD oddly protective against this outcome, whereas AI steatosis score was associated with an increased risk of this outcome. So overall, we found that the actual steatosis scores may be lower than what pathologists have been annotating. And this study suggests that the AI platforms may be able to better discern which donor livers on biopsy are at greater risk for EAD relative to the pathologist review. In the future, we're interested in developing the AI platforms further out to identify other unfavorable histologic features, such as fibrosis and hepatocyte ballooning. And we're also interested in developing a device that can be used as a point of care tool in the field with teams that go for procurements to help streamline the process of determining the donor liver quality to bring these livers back to recipients sooner. I want to thank our multidisciplinary team that made this work possible, led by our PI, Dr. Mark Melcher. Thank you so much for your attention. I'm happy to take any questions you have.
Okay, great. I just want to point out that Raja is a 2-time Holman winner, having won last year as well. So congratulations on that. And we're open for questions in the chat box. To start it off, I'm not even sure if this completely applies, but I bet that you'll educate me about that. You mentioned the variation among pathologists as they look at different donor slides. When you applied the AI program multiple times, did you see variation if it was run multiple times, or did you routinely run it multiple times and take the average?
So we only ran, so the AI platform score was ran once at the end with the UNet platform for the prediction set. When we ran it initially, there was not too much of a difference between the different platforms that were used between the FCN, the 5 and the 10 versus the shallow UNet and the regular UNet. But most of the prediction comparisons, especially the ones that I showed at the end for the median steatosis scores, were mainly done for the UNet platform.
Okay. Dr. Hahn says, great work, Raja. How good was the pathologist concordance?
So not great sometimes. So it would vary depending on the quality of the slide as well. And that's something that I wasn't able to touch on here, but we're working on in our group too, to try and figure out a better way of looking at slides beyond just sometimes a photograph of a slide, which can be done sometimes at the time of procurement. So sometimes the quality can really affect how the assessment is done. We initially started with an attending pathologist and a resident pathologist, and then we had several other attendings that also looked at the same slides for comparison. And some had a significant discrepancy, but others seem to have a comparison, let's say maybe about 20% versus 40%. But the ranges were not considerably different, like 10% or something greater than 50%. So there wasn't that much discrepancy.
Okay. Dr. Hahn also asks, can you add other patient variables such as BMI to better train your algorithm?
Definitely. So what you could do for not just the algorithm, but also for the interest of testing with the Cox regression analysis, we want to look at things like BMI and also the indication within the recipient as well for transplantation to see how these could impact their outcomes. So BMI can definitely be added, as well as I mentioned, the other histologic features we're hoping to build out within the platform.
Okay, great. Dr. Jeffrey asks, will there be an influence in sample preparation? And Dr. Jeffrey, if I misspoke there, please correct me.
So I think she might be alluding to how the slides can differ depending on potentially the staining that's used. For example, there's a different stain that you would use if you're trying to look at fibrosis versus if you're looking at just steatosis. And that definitely makes a big difference. So while we've only been looking at H&E slides right now, so it'll be interesting to look at how this varies when we look at other types of stains like trichrome. So our group is also trying to identify a way to define or at least score as well the degree of artifact disruption on the slide, because we think this also can contribute not just to pathologist discrepancies, but also discrepancies that may impact what the AI score ends up being. So there actually isn't much in the literature that we've been able to find so far, similar to steatosis that goes from 0 to 100% that tells you how much steatosis is present. There's nothing similar for that for artifact disruption that's grade 1 through grade 4. So we're trying to develop something like that that can help give us guidance when interpreting these slides.
Okay. Dr. Escovel says, great work. Is microsteatosis the reason for overestimation by the pathologist? And notes that macrosteatosis is the one associated with EAD in most common studies.
So that's a great point. So there are different centers that make a distinction between what's called microsteatosis and macrosteatosis. So these are also known as like large droplet or also small droplet fat vacuoles. So we use what the pathologist would score as total steatosis, which I interpreted towards macrosteatosis. But when looking at microsteatosis, that would definitely potentially cause different scores to be generated too. So that's something we haven't done yet, but we're interested in as we build out the platforms to include other histologic features.
Okay, great. We have two more maybe short questions. Dr. Dunn says, will you get similar results if a different training set was used?
So potentially, so it kind of depends on whether you're using, so that's one of the things that I alluded to when mentioning if we looked at the different indications for requiring transplantation. So for example, if you're looking at a patient that potentially had an older donor that had potentially more liver disease, of course, if you have a cohort that tends to be older than the one that we use, I would suspect that you would have more hepatic parenchymal disease, and that could lead to greater rates of steatosis and some of the other factors. So that's part of the reason why we want to incorporate a Cox regression analysis so we can try to control for these features. But definitely if you use a different training set from our institution or from others that see a different type of population, like for example, in Texas, I assume some of the donors there may not have the same type of histopathology that you would find on a biopsy relative to what we would see here in California.
Okay, and then last question, have you tried using a lipid stain to train your algorithm instead? And that's from Carlos Ayala.
So that's a great question. So we haven't done that yet because we wanted to start with H&E staining. And now that we're going to be building out to other types of histologic features that require other types of staining, like trichrome staining for fibrosis, we do want to explore other types of staining. But that's definitely moving forward steps to do.
Okay, great. Well, thank you so much. Nice work.